Today we're going to talk about bias in research, especially in diagnostic studies. And this is always present, but we have to try to reduce the effect of this on our results so that we are sure that we can trust what we are doing. So there is different phases of research, and you can have different types of biases in these areas. The pre-trial bias is always a bit more in your control, like study design, selection bias, and channeling bias. Then you have trial implementation, which is often a bit more tricky to navigate, like interviewer bias, chronology bias, recall bias, and misclassifications. And then you have the data analysis and publication bias, which is most often out of your control. The differences between diagnostics and interventional studies also comes into play when we look at bias. So you have to have specific investigations to see what diagnostic bias looks like, and you can't just take data from interventional studies and the bias is present there and try to transpose it on diagnostics. The major difference is that interventional bias has a control group, which is your placebo group, compared to some treatment outcome, and you measure these, whereas diagnostics most often is comparing a diagnostic procedure versus a gold standard procedure like blood tests or histology or something like that. Or maybe a well-known tracer radiopharmaceutical like PET with glucose, radioactive glucose, versus a new tracer, and try to look at if it's more optimal for what you want to investigate. So, terms that you should know is sensitivity, specificity, positive predictive value, and the diagnostic odds ratio. Sensitivity and specificity are independent of the population of interest, whereas positive predictive value and negative predictive value looks at how useful the test is, and it can then be dependent on the prevalence of the disease in the population of interest. It is good to view them as is in this figure, where you will have true negative tests, true positive tests, also false negative and false positive, and then you have to tweak your sensitivity and specificity to get the best diagnostic odds ratio. So, if there is biases present in your case control studies or your cohort studies, all of this will build up to a pyramid of biases. So the first studies you do influences your meta-analysis, and finally how these new diagnostics will be applied in the clinic. So it's very important to reduce the prevalence of bias. Publication bias is a very big issue that we cannot currently negate, where you have a hypothesis, and if your hypothesis is supported, it gets published and reported, and there is also very few replication studies. It's the publish or perish situation, where if you have negative data, it fails to support the hypothesis, you will not be able to publish this. When you choose a small sample, it naturally leads to bias, so sample size is important. Then you have a thing like coincidence, where you might have no control over the selection, resulting in a homogeneous population. And then heterogeneity in your study population could be of some issues. So the best would be to do a multi-center trial where you have different backgrounds of your patients in different cities, countries, and so forth. Then there is the problem of cherry picking, and as a researcher you should always be aware that you don't fall in this trap. There is the truth, the whole truth, and nothing but the truth. So You have to not focus on data that support your hypothesis, and you should not get so emotionally involved with your data that it becomes a problem. So ways to reduce bias is mentioned here, but I'm sure it's not an exhaustive list. If you can think of any other ways, please comment down below in the comments. So you can choose clear clinical outcomes, defined patient characteristics, and disease characteristics. So before you start your trial, you should give parameters that are clear and not ambiguous, and you know what you want to measure. Always confirm with histology, diagnostic blood tests, cell cultures, and biopsy. This is everything you can do to reduce give more information is important, and this reduces the ambiguity. Choose the gold standard and not a less superior measurement or diagnostic. So I would say not the silver standard, because if you compare your radiopharmaceutical or your diagnostic test, you should be comparing it with the best, otherwise it has an unfair advantage. Insert blinded and double-blinded observers if you can. This is also important to notice that there is a problem with retrospective analysis compared to prospective. Not saying we should not do retrospective studies, but a prospective clinical trial is invaluable for progression of your diagnostic test into the clinic. Internal and external validity is also important. Internal validity is where there is a less, it's a very well controlled study design, and the patients are chosen beforehand with criteria, whereas an external validity is where you have a non-homogeneous population under real clinical conditions. Both have pros and cons. With internal validity, there is not confounding factors and you know exactly what you are dealing with, whereas with external validity, there is lots of other interventions that can have an impact. Small study bias is a problem, and it's definitely the more patients you include in your study, the better the statistical analysis. Finally, a shocking study that was published very recently, it's still in press, is the scientific fraud, publication bias, and honorary authorship in nuclear medicine specific. I would invite you to go read, but 4.3% of nuclear medicine authors admitted to scientific fraud, 21.3% reported witnessing or suspecting fraud by somebody in their department, and 78.4% agreed to the presence of publication bias. I don't know what this means for our future, but I think we can all do a little bit better. Here is some references that you might find interesting to read. That is what I used during this small presentation, and if you liked it, please subscribe.